Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Health Insights That Matter. In this podcast, I am joined by medical dermatologist Dr. Sean Quatra, who serves as director of the Johns Hopkins Itch Center. Today, we are talking about chronic pruritus, and we'll get into that into some degree of detail, which could be associated with some inflammatory skin diseases, some systemic diseases, neuropathic conditions, and even psychogenic disorders. So, Dr. Quatra, let me welcome you to your podcast, and thank you so much for joining us today.
Thank you so much for having me. I've listened to some of the other episodes, and I'm glad to be on.
I want to start off in saying a really basic question, which is, why does itch matter?
It's a great question. Sometimes when I tell folks that I study and treat patients who have chronic itch, they may not appreciate how severe the burden can actually be. But what I would say to that is if you look to history, you can see just how powerful and how devastating chronic itch can be. Dante's Inferno depicts hell as 9 rings, and you have each one for a different sin. One of those rings of hell is the burning rage of fierce itching that nothing could relieve. That's the 8th ring. Another real life example is that actually in ancient India, one of the forms of punishment was having to be in a cage with an itch-causing substance and itching. And they found that actually a day of being in such a cage and having such intense itch was a greater deterrent than even being in prison for many years. And so that highlights the severity of chronic itch. And also we did a study in our itch center from our patients, and we found that folks who have chronic itch greater than 6 weeks, the impact on their overall quality of life is similar to that of stroke, heart failure, and many other systemic conditions like type 2 diabetes, et cetera, that are oftentimes more talked about.
That's really amazing. And I'm glad that you also clarified what do we mean by chronic. So you said 6 weeks or more. I had a reaction to paper tape and didn't realize it for several days. I was in the ICU at the time as a patient, and I started scratching where all this tape was. Just dug and scratched. And then I started peeling the tape back, which I wasn't supposed to touch, but I was like, I think my itch is underneath of this tape. Let me pull this side. I got all of the tape off before a nurse discovered what I was doing and had blisters all over my abdomen. I dug those until they popped and I said, don't anybody tell me I can't scratch this itch. I just don't tell me that. And they're saying, look at your tummy. Look at I said, I don't care. I feel better when I dig it, so I'm going to dig it. They put gloves on me. I took them off. I had never experienced anything like that before, and it went on for about 2 days, which to me, I would have considered myself having a chronic itch in just 2 days rather than going a whole 6 weeks. Oh my gosh. And I did. I thought, gee, there are people that have a chronic itch all the time. I just don't know how they have any quality of life because it is so disruptive to quality of life. And of course, it took so long for me to heal because I had just ripped into those blisters and I didn't care. And it hurt to scratch them, but that didn't matter either. As long as I could get the itch in a little bit of control for a few seconds, I was going to do it. And I dared anybody to stop me. And usually I'm a very cooperative person, but not at that time. Those 2 days in there, I was like, wow, this is god awful.
Oh my God.
So I do want to make clear to our listeners, and we have tens of thousands of them out there that will be listening to your wisdom today, that we're literally not talking about the occasional itch, but that chronic itch and you defining it as being 6 weeks or more. And just hearing you say 6 weeks, I'm like, I wouldn't make it. I don't know what I would do, but I would not survive. Is chronic pain usually related to chronic itch?
It's a great question. And I think it comes back to your story you were telling me about the tape. and the willingness and the urge to scratch. Because actually, if you think about it, what you're doing in that situation, the act of scratching is actually inducing a pain to take away an itch. And so pain and itch are actually linked very much so in terms of different pathways that are involved. Basically, it starts from the outer layer of the skin. The nerves go all the way out, basically to the outer layer, and they trigger the process of itch and also pain that goes from the skin all the way to a place we call the dorsal root ganglion and the spinal cord, and then up to the brain. What's really interesting is that this is a bidirectional process. Even when you're feeling stressed, you can start itching. And actually, I do that. So I have a history of eczema and I have allergies and get hives myself. And sometimes when I personally am feeling a lot of stress, I will then break out in a rash. Sometimes itching that doesn't have skin lesions or hives, and sometimes they do. And that's a common phenomenon. And similar things occur with pain. So I think chronic pain and chronic itch are linked very much so. And a lot of the therapeutics that are used are similar. Neuropathic pain refers to pain that may be secondary to disease or any type of dysregulation of the nerves. And similarly, chronic itch can also be due to any disruption of those nerves. So things like gabapentin, which is a drug that can help with the neural transmission, particularly spinal processing of both itch and pain, are used for both conditions. And actually several antidepressants can be used for both conditions. So there's actually a lot of overlap between the two. And these nerves that transmit itch, we already talked about transmitting pain, but they can also transmit temperature and vibration. So that's one of the reasons when folks are really itchy, and in what I oftentimes call an itch emergency, we're also thinking about disrupting processing. So if you're really itchy, if you put ice packs on, that can diminish that signal. Pain, the act of scratching, can diminish that itch signal, and also different vibrations. So they are totally linked.
That is really fascinating. Can you describe for us what are the various systemic causes of chronic itch? And I want to look at three particular categories right now. One would be the types of inflammatory diseases, infectious diseases, and also tumors.
Absolutely. So in terms of inflammatory diseases, this is a little bit more straightforward to diagnose because you're going to actually see an eruption. So atopic dermatitis or eczema is very common. Millions of people have this in the United States and around the world. And oftentimes what you see are these red appearing lesions that are very itchy on oftentimes the creases of the elbows, behind the knees. And these folks oftentimes have also seasonal allergies and asthma like myself. Similarly, psoriasis has very scaly plaques that oftentimes bleed from the itching, and they are usually distributed all over the body. Contact dermatitis usually is an allergy to something in particular, a cream, a nail polish, and that usually appears in a particular area. I myself had a nickel allergy before, and so the belt buckle was contacting me near my belly button, and then I developed a significant rash. But as dermatologists, we see it all the time. You can see it where your rings are on the fingers, even different from nail polish. It'll show up on the eyelids because that's a common area that scratch so many different areas on the body. These are more easily diagnosed because you can see them and they have a unique morphology, but they can be very itchy. In terms of infections, it's actually interesting. So if you have a superficial fungal infection, a fungus, then sometimes that can be very itchy. Folks may have experienced that in between their toes, they have itching. So that's actually athlete's foot. It starts in the toes. So if you have itching between the toes, that is usually sensitive for having a fungal infection in the skin. And we often tell folks that's a good time to use the over-the-counter antifungals so you don't get that to spread necessarily to the nails or even other parts of the body, like in the groin or other areas like that. There's also something called scabies, which everyone's a little bit terrified of, but we've seen several folks come in between the fingers. There's a lot of scaling, and scabies is caused by the scabies mite. So these folks are intensely itchy. And, there's several other infectious causes. And then tumors. So actually, if you can see lesions that are in specific distributions on the body or even whole body redness, we oftentimes are working up or underlying lymphoma. That's another important thing to keep track of, is that you can have inflammatory, infectious, and then also tumor types of causes that are all more visible forms of itch.
How is herpes simplex associated with this?
Herpes simplex can be itchy. It can be painful also. It usually appears with grouped vesicles, so fluid-filled blisters that usually appear in certain distributions on the body. So if there's grouped bumps that are oftentimes fluid-filled and oftentimes have pain or itch, those are common presentations. It's not going to be throughout the whole body. It'll be more likely to be localized on certain areas. Later in life, folks may have a shingles outbreak, why it's important to get the shingles vaccine, because that can also happen in localized distributions where the nerves come out. But one of the consequences of having herpes simplex and not treating it quickly and appropriately is that then you could have some damage to the nerve. So there's actually a lot of folks who have herpetic neuralgia, which can manifest as pain, but also itch. I've seen both if it's not treated right away. So that's why we put a lot of priority and emphasis on treating patients who have a herpes infection quickly.
That makes very good sense. I think I'm right in saying that not all root causes of chronic itch are actually visible. Is that right?
Absolutely. So itch can present with a rash or without a rash. And that's one of the most interesting aspects of treating itch. It's a little bit like being a detective because we're always looking for clues and signs, but many folks don't have a rash. So recently our group did a genetic study of folks who are itchy and have chronic itch, but they do develop lesions in the body, small bumps, nodules. We call it prurigo nodularis. And we found that there are folks who are more genetically susceptible to developing itch with skin lesions or without. And so that helps us explain why do some folks present with bumps and itchy nodules and not. So there's many folks who don't have that rash, and then we have to start thinking outside the box. So things I always think about are, could there be any issues with the blood or blood dyscrasias? So things like polycythemia vera that has a very high hemoglobin. If you have a very low hemoglobin, iron deficiency sometimes could present with chronic itch. So that's why we always want to look at in the blood. Other diseases that can also be associated with itch are type 2 diabetes, hyper and hypothyroidism, any diseases that have obstruction of biliary flow or liver disease, so cholestasis. Those are important causes. Chronic kidney disease is another important cause of itch. So in our itch patients that don't have a primary rash, we're oftentimes doing a workup just to make sure that the kidney looks okay. Sometimes tumors. Actually, Lisa Sanders is part of the New York Magazine, one of the writers, and she actually is inspiration for House MD. And she has a lot of diagnostic columns. Oftentimes, she talks about chronic itch. And so one of her recent columns actually focused on a person who had chronic itching, very acute, so just been going on a few months. And then later was found via chest x-ray actually to have a Hodgkin's lymphoma. And our group has actually done more research recently. We published in JAMA Dermatology about when folks develop these malignancies, if they develop them, and how common it is. And one of the things we found is that chronic itch that's newer onset, so just been going on for a few months or less than a year, and is very sudden onset, doesn't have necessarily a classic inflammatory disease like eczema or psoriasis, and just seems to come out of the blue. Those patients are at slightly more increased risk of having a Hodgkin's or non-Hodgkin's lymphoma. So I'm always asking itch patients, do you have any fevers, night sweats, chills, unexpected weight loss? Those are really important questions, and making sure folks are up to date on their age-appropriate malignancy screening. Although it's rare, it is more common more initially in the initial time point of itch when it starts. If someone's had itch, chronic itch for 5 to 10 years, then they're less likely to have that underlying malignancy. Then we also have systemic infections like HIV infection, hepatitis C. Those are often things to think about. We're not usually getting this in everyone, but if folks may have particular risk factors, it's important to consider. We've been seeing also a lot of folks who have neurological diseases or neuropathic disorders. So something that we see, especially as folks age, is that in the spinal cord and in the spinal discs, there can be degeneration of those discs, and they can narrow and they can shorten, and they can also impinge the nerves that are coming out. And so that can sometimes cause a significant issue. And folks oftentimes are itching just on the scalp or the upper back. We call that notalgia paresthetica on the back, or scalp itch. And that's usually due to either cervical or thoracic nerves. So upper neck or back when they're coming out. When we get imaging, sometimes we're seeing that degenerative disc disease, spinal impingement. So that can certainly contribute. And if anybody's had an accident or degenerative conditions, that's important to think about. There's also the side effect of medicine. So now with the revolution going on in medicine with chemotherapy and also immunotherapy, we're seeing a lot of itch that's happening. So several drugs like EGFR inhibitors, PD-1 therapy is now the standard for melanoma. Well, I have so many patients who have had chronic itch. And what's actually interesting is when we looked at these patients and their survival, our group, what we found is that folks who actually have itch, and oftentimes folks who have skin symptoms, live longer. And the reason for that is because these drugs are stimulating the immune system. They're helping the body fight an underlying malignancy. But in that fight, they're also stimulating these immune cells, which can cause itch. So I think when I explain that to folks, there is a silver lining, at least for these folks, for having that chronic itch.
So you can feel it working.
You can feel it working. I'm so glad that we know that your immune system is being activated. And then finally, there are some types of itch that are also related to psychiatric diseases, but also chronic itch can lead to the development of psychiatric conditions, because if you have sleep disturbance from itch, then that can be the gateway to anxiety, depression, and many other conditions. It's truly this bidirectional process.
Yeah, I'm sure it is. Oh my gosh. Can we talk a little bit more about treatments? You've mentioned about gabapentin as one of the drugs. What other over-the-counter, first of all, and then talk a little bit more about prescription that you've seen has been of benefit?
I think this is a confusing area because there's so many different causes of itch that are unique. And so based on the cause of the itch, there are appropriate types of therapies. So first, I'll talk about therapies that are related to itch that has an issue with the immune system. So if you can see a rash on your skin, then that's likely telling you that there's inflammation there. And so over the counter, you have over-the-counter hydrocortisone ointment or cream that can be applied twice a day for around a week or so, sometimes longer to certain areas. And that's oftentimes a nice option, especially if you see a rash, you see it's red, you see that inflammation. That's really important to do. Other things that we have are topical steroids that are prescription. So we also have prescription topical steroids that come in different strengths, low, medium, and high. So those are all options that we have. Then there's a lot of agents that are over the counter that are thought to act on the nerves and the nerve transmission. So one anesthetic that's used, it's called Pramoxine. That's over the counter in several products, and it's thought to dull the sensation of itch. And they come in lotion or pump bottles that you can put on. Sometimes I have folks even put it in the fridge if it's not working. And again, that's better for the type of itch that doesn't necessarily have that red rash, that doesn't have that clear inflammation. So Pramoxine's one, but then there's several other types of anesthetics over the counter with lidocaine. There's other compounds. There's other agents that modulate the nerves, one with strontium in it. There's agents with capsaicin that can potentially help, that is used to get all the neuropeptides out and then hopefully reduce the itching. But again, that's more for non-inflamed skin. So those are all excellent. And then there's also a lot of moisturizers. Sometimes they have oatmeal in them, colloidal oatmeal, and that can help a lot. That can be very soothing. Say if you're more likely to have eczema, oftentimes we're recommending even oatmeal baths or colloidal oatmeal-based lotions. A lot of creams are very important. So what I tell folks is you have this water barrier in your skin. And some folks with itch disorders, like myself, who have eczema or atopic dermatitis, are predisposed to lose water and to be drier. So right when you get out of the shower, this is what I do. Right when you get out of the shower, when I'm not lazy, is you'll try to, within a few seconds, pack on a thick cream. Doesn't matter, there's several excellent brands, but a thick cream, or if you can't get yourself to do a cream, at least a lotion in a pump bottle, and putting it on quickly because you are in a race to capture that moisture. And if you capture that moisture in the skin, you're going to have that barrier. The reason the barrier is so important is those nerves go almost to the outer layer of the skin. And if you have that water barrier, then you can prevent all sorts of things, allergens in the environment, pollutants. Oh my goodness, we had this air pollution from that wildfire in Canada that was making me itchy and I couldn't breathe. All sorts of things that could set it off. And so that's one of the things you can do to get ahead of the disease. We are actually living in a revolutionary time right now for itch in terms of prescription therapeutics as well. So there's been a lot of development in pain, and now there's becoming a lot of development in itch. And so there's a number of agents that are monoclonal antibodies, things like dupilumab, which is an injection that actually targets a receptor called IL-4 receptor alpha. That's very important in eczema, and that's given a few times a month. And there's several other agents like that target IL-13 and IL-13 receptor alpha-1, IL-31 receptor. I could go on, but there's a lot of different drugs that are coming in that all help to block the itch scratch cycle. In my view, they're actually a lot safer than things like steroids, prednisone, things that target so many different things in your body. So we were very fortunate to have those. And there's also new drugs called oral JAK inhibitors. There's several of those that are available now and approved for atopic dermatitis, like abrocitinib or upadacitinib. And those drugs are able to more specifically target the itch as compared to prednisone or other non-specific therapies. So we are, I believe, living right now in the golden age for folks who have chronic itch, and each condition is now having development in each specific area. So it's actually made our clinics be a lot easier, and we're learning a lot more. The folks that I think are still struggling, that there's no FDA approved therapy for, is folks who have neuropathic itch. That's itch that can be associated with spinal disc disease and nerve fiber derangement. We're doing a lot of research to help figure out these subgroups of patients who seem to have itch of unknown origin, but we know that some of them have more immune involvement, some of them have neural involvement. So to be honest, we've been doing a lot of different therapeutics. We're about to publish our first in humans report of even utilizing ketamine infusions along with our colleagues in pain medicine, anesthetic injections. We're using all sorts of drugs like gabapentin that I mentioned. It's sister medicine, pregabalin, antidepressants off label, but there's a huge need for greater discovery, greater research, new therapeutics, new trials. It's one of the reasons my lab, which is a translational and basic lab, also has been doing clinical trials to try to help these patients who are suffering.
That's wonderful. I'm a big fan of clinical trials. I encourage patients to participate in them because that really is the cutting edge of innovative therapy. Have you had any patients who have lost a limb, lost a leg, lost an arm, a hand, that are having chronic itching problems? They'll tell you that the itch is in their hand, but their entire arm is gone. Or my toes feel itchy, but their foot is gone. Have you experienced any patients like that? Which we refer to as having phantom limb sensation and phantom limb itch or pain.
Absolutely. So I have had a few folks who in particular were amputees and have felt pain, but then also itch. And I think that the nerve severance that occurred is largely responsible for a lot of these sensations. And the other thing that's so interesting is that these limbs that folks have that are missing, also those nerves have those relay stations that I was discussing, those relay stations in the spinal cord and the dorsal root ganglion and in the brain. And so that we're learning that there's also central centers in the brain that can be disrupted and can be responsible for these phantom itch sensations. It is a problem that we're seeing. And again, that falls into more of this neuropathic itch bucket that's a little bit more difficult to.
Yeah. So I'm a 31-year breast cancer survivor, and my initial surgery was a modified radical mastectomy without reconstruction. And then 2 years after that, I had the same trouble in the other breast and went through a second mastectomy. And both times I had phantom limb sensation and phantom limb itch.
Oh my gosh.
It was awful. I learned, which I thought was very interesting, I learned that the nerve to the nipple somehow or another had managed to get into my armpit. After many months of dealing with this, I could dig my armpit and make the nipple itching stop. I finally met with my surgeon, and said, can you help me figure out where you put these nerves that are still, I guess, on the chest wall? And he said, oh, well, yeah, you would have one under here. And I said, we've got to educate patients about this. So he said, I haven't had any patients tell me they've had phantom limb. I said, I think they think they're crazy. I said, but the brain is treating the breast as if it is a limb. And a small study that we did, but certainly noteworthy, was that 80% of our patients that had mastectomies without reconstruction had phantom limb pain or itching and were afraid to tell anybody because they thought it was a sign that they were losing their mind. So we make a point of letting, obviously, patients know. Some patients have also said, if I'm coming down with a cold or flu, I will feel like my breast that's gone has gotten huge. Isn't that fascinating? Absolutely fascinating. So the way our brain processes this and sends messages down those nerves is something that we need to discuss more and prepare patients for, including those that have, whether their amputation is due to diabetes or due to a car accident. We need to make them aware of what kind of sensations they might experience and when they may need you.
Absolutely. And this is such an important issue. There's been some research in the 90s where they found that there are mirror neurons. And so mirror neurons are actually really important in the sensation of pain. And we've also found that they're important in the sensation of itch. And this has actually been explored also in phantom limb pain, the effect of mirror neurons and the importance of the brain also. And so it's these circuits that need to be rewired. So I'm glad you're telling folks about this because I believe there is a significant component of shame and also feeling comfortable to know that there's an anatomic reason in the brain, other areas why you're feeling this way. And it can be, I'm sure, very disruptive for quality of life.
Right. I had reconstruction done 10 years after my second mastectomy, and all of those annoying symptoms went away. That was a nice gift. Both were nice gifts, to have the reconstruction, but also to have that crazy sensation go away. I wanted to ask you, are there racial and or ethnic disparities that you have encountered in your research behind chronic itch? Do you see this more in Caucasian people, in women, in men?
Anybody can suffer from chronic itch, but when we looked nationally also, at which groups tend to be more affected. In the United States, it appeared more African and Asian ancestry folks tended to have chronic itch. And one thing we've found is that there actually are some differences in how itch can appear clinically. So folks who have eczema, in some of our African-American patients or Black patients, we see that it looks different. There's more bumps to it. There's more of an involvement on the outer layer of the arms in addition to the flexural areas. So there can be very significant differences. Also, some factors that may lead to greater water loss, so transepidermal water loss and things like that. So we're definitely seeing that. In other itch conditions, like I treat one where folks have bumps all over their body called prurigo nodularis, we find that oftentimes these bumps can be a lot more thickened, fibrotic, especially in African-American patients. So we're lucky being in Baltimore, being able to see a wide variety of patients in different diseases and disease presentations. And so we have found some racial differences and ethnic differences in the presentation of the disease, how it looks like. And we know that burden and also social determinants of health are so important. Some forms of itch mirror society in many ways because you have socioeconomic factors, social determinants of health that really contribute, pollution. A lot of the things that you think about in society can be mirrored in who actually develops chronic itch because your skin is so close, the closest organ to the external world.
That's a good point. And I think that people don't always realize that our skin is an organ.
Yeah.
I was reading an interesting article which talked about many repercussions for those suffering from chronic itch that remains untreated. Can you talk about that a little bit? So if someone doesn't have an individual like you, a specialist like you, or even know that you exist, which would also be sad, what are the ramifications? What can happen?
We actually did a study looking at chronic itch patients, and particularly the folks who had severe itch that they had some sleep disturbance. And one thing that was very interesting is that those folks had more inflammation in their blood. So they had increased levels of a marker of actually inflammation that can also be related to cardiac risks called C-reactive protein levels, as you know. That marker was significantly elevated in folks who had chronic itch and also sleep disturbance from it. And subsequently, we've done a lot more studies from the bloodstream of patients who have had chronic itch. And we've been finding that folks who have itch is not, in many cases, just skin limited. It's in the bloodstream and can cause all sorts of things and be related to the development of a lot of different diseases. So now when I tell folks about itch and we talk about therapeutics, I also talk about the consequence of not treating the disease aggressively and the consequences of sleep loss, especially sometimes with parents of kids too, to make sure that's clear that if your child isn't sleeping well, that can affect their functioning in school in different domains. With adults definitely having risks for heart disease and cardiometabolic diseases, that's something that we're really understanding a lot more of. That this is not just skin limited if you're having itch throughout the body. It's something that we've been doing a lot of research on from our studies funded by the NIH and other organizations to look at even blood signatures of disease.
That's fascinating to be able to look at the blood and see more about what's going on systemically in the body, for sure. If someone listening today believes that they are suffering from a chronic itch, what steps should they initially take to seek a solution?
I believe dermatologists are one of the guardians of chronic itch. And so it can be helpful to see a dermatologist to be evaluated, especially if you have a rash on your skin, and to get the appropriate workup with labs as well. We want to make sure that there isn't anything underlying going on. So things to think about: are you also having fevers and night sweats and chills? Anything sudden that you've noticed? Are there rashes on your body? And also appreciate that folks should be seen, because it's important to treat early so we can prevent a lot of different consequences, a lot of different types of disruption in your life.
Is there anything else that you would want to make sure that our listeners learn today from you?
I think the most important thing is having that respect for itch, like we have respect for pain, that this is a very serious condition. And the whole field has struggled for a while to make a lot of progress before the last few years because of poor recognition. And I think now there's greater funding and understanding of chronic itch, and as an independent entity as well. And having that healthy respect from a practitioner perspective, from a patient perspective, respecting folks who are going through and suffering from chronic itch can be the most important thing to take away.
And I'll bet you, while our listeners have been listening to you today, I bet you they've been doing some digging and scratching of some spots.
Oh, yeah. Everybody, I'm scratching too. Whenever I talk about itch, I scratch too. It makes it very tough to give talks.
I'm sure it does. Even I've been sitting here going, ooh, I think I feel something that I'd like to scratch, but I'll try to hold off and do it after we're done.
My wife makes it hard for me too, because I go through a long day of treating patients. Then she comes home and she's like, hey, can you scratch my back? I get no reprieve.
Oh my gosh. Well, thank you so much, Dr. Quatra, for your time today and all of your information on chronic itch. We hope you will join us next month for another educational and information podcast featuring another Johns Hopkins medicine expert. To learn more about important women's health topics, if you live within the vicinity of Baltimore, you were invited to attend A Woman's Journey next in person as an event, and it's scheduled for Saturday, November 18th, and will be held at the Marriott Waterfront Hotel down at the Inner Harbor. To receive information about this event and other women's health content, please visit the A Woman's Journey website at hopkinsmedicine.org/A Woman's Journey to sign up for our monthly e-letter and read about upcoming podcasts and programs, and to sign up for our upcoming free Conversations That Matter webcasts. Again, thank you so much, Dr. Quatra, for joining me today.
Thanks for having me.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.